afternoon. Welcome to Austria, the Styrian state, a place of kindness, and welcome to a classic Viennese coffee house, a place where you can sit down, read the newspapers, drink a coffee, and have a casual chat just with your seating neighbor you just met a couple of seconds before. Today we have two gentlemen in this coffee house who don't need any more introduction. Nevertheless, let me mention who's sitting here. It's Rob McSweeney from Belfast. You might know him from Critical Reviews meeting in Belfast and also the Critical Care Reviews blog. The gentleman to his left side is Professor Jean-Louis Vincent from Brussels. I would say the eminence in critical care and intensive care medicine. Me and myself, you don't need to know my name. I'm just a waitress serving this both gentlemen. So let me just grab my towel. Hello.
Hello, hello. Hello.
May I serve a coffee?
Coffee? No, a beer.
A beer.
Yeah.
We'll take, yeah, absolutely.
Imagine.
Yeah, for sure.
I like you, I like
You're
beer.
welcome. For you?
Coffee if you want.
Okay, coffee is a little bit quicker.
Okay, I'll take the coffee. Okay.
Do you prefer to read the newspaper or the new papers?
No, I think we're gonna have a chat.
Yeah, I'll take the newspaper.
The newspaper?
Yeah.
Okay.
Some news about Ukraine, if possible, because I'm very worried.
Oh, today we have the Falter. It's a story on Putin. For you, the NAGM. We will work on this.
I think I have no choice, my friend.
In the meantime, the recent issue. The beer will come.
No, thank you. No, I'm kidding. No beer at this time of the day.
So Jean-Louis, good to see you again.
Are we supposed to start?
I think we are. I think we have been served. We are in our coffee house in Graz, rather than Vienna. My issue of the New England is a little bit old, but the coffee is here. So we're going to talk about different aspects of landmark papers and different aspects of critical care trials. So I have some of the more recent trials that I'll put up and we'll have a chat about, and you've got a talk on.
I will make a brief introduction, if I may have, because I think that before we discuss some specific trials, I think, may I go ahead, or will it be projected there? No. And how can people look at the slides? Ah, voila. So first, thank you very, very much for the invitation. It's a real honor and privilege to be in this lovely city at this excellent meeting. No. Prosit. Voila. As you heard, I am primarily an intensivist, but I have been professor of intensive care medicine and emergency medicine, and I have been in charge of our department of intensive care and emergency medicine. And I am interested in the very severe aspects of emergency medicine, not the little things in the ER. That doesn't interest me. But I like trauma, I like cardiac arrest and CPR, I like shock, etc. And as you know, we organize every year in Belgium this international symposium on intensive care and emergency medicine, because we believe that we need to work together for the severe cases. Now, speaking about trials, there is no doubt about the fact that at the top of evidence-based medicine, we have these multicentric, randomized controlled trials bringing the best evidence. However, we have major limitations when we start to target mortality, especially in heterogeneous populations. And very often the populations in the emergency rooms is very heterogeneous. And my first point, and maybe Rob would like to comment on this, is the question, should we do a randomized controlled trial on anything? What about these pragmatic trials? You know, in the past, we had very small patient populations, and that was too little, of course. We went for larger populations, for multicentric studies, but I'm afraid that in these pragmatic trials, nowadays, the number of patients counts more than the quality of the selection of the patients. And also, we take any question without thinking very much. And this is the best example. The trials we have seen recently comparing saline solutions to so-called balanced solutions. We all know that saline solutions have 0.9% sodium chloride. They are very simple solutions, but of course, they contain a lot of sodium and especially a lot of chloride. It's very simple to understand. So this is an old study from the last century showing that if during surgery you give only 2 liters of normal saline in 2 hours, you will see an increase in sodium level, in chloride levels, and a fall in pH if ventilation is controlled. Now, do you think hyperchloremia can be good or that it doesn't matter? Can you tell me what is the abnormality that does not be associated with worse outcomes? Tell me. Hypokalemia, hyperkalemia, hyponatremia, hypocholesterolemia, hypertriglyceridemia, whatever, it's always associated with a worse outcome. Why would you induce hyperchloremia in your patients? But if we go a little bit into the details, we know that the major concern is renal dysfunction. This was shown in 1983 in this excellent study showing that hyperchloremia can decrease renal blood flow. And later on, other studies have confirmed the phenomenon. It's something which is well accepted in physiology. As we know, balanced solutions represent a heterogeneous group of solutions which have other substances in their composition. Okay, now there is not just one balanced solution, right? There are several types. We can already mention Ringer's lactate solutions, Ringer's acetate solutions, plasmalite, etc. And as shown in this recent trial, with these balanced solutions, of course, there is less increase in chloride levels than with the so-called normal saline solutions. So as we wrote a number of years ago, Daniel de Backer and I, if you give saline another liter, if you see the chloride levels going up, if you're a good doctor, you will stop immediately the solution. And of course, you will never find that this could be harmful. And people will say, of course you don't see it's harmful because you didn't give enough. And if you are a bad doctor, you don't look at the chloride levels. You give chloride again and again and again and again. And then people will say, of course you are giving too much saline. Of course it's harmful. How much do you drink a day? Beer, wine? I take only 1 glass of wine a day. But that's much too much. No, I don't do that. No, I don't need a randomized control trial to show me that this is bad. Look at this initial randomized control trial. No harmful effect. But what is the risk again with saline solutions? Hyperchloremia. Just say that again and again. What were the chloride levels? Oops, we forgot to measure them. They did not measure chloride levels. Can you imagine that? What kind of reasoning do these people have? The next study will be on potassium chloride without measuring potassium levels. Oh, if you give too much potassium, it can be bad. I did a prospective randomized control trial to show that. Look at these recent trials. They continued to give saline until they could show that there were more signs of renal dysfunction. I wrote this letter saying, you know, we need to stop this because people are trying to harm people to show that a biochemical abnormality can be bad for them. So I raised ethical questions, and I still do. I think ethically, in prospective randomized control trial, you should not harm one group of patients. Look at the chloride levels in this study. Why would people continue to give saline when the chloride levels increase significantly? More renal dysfunction. And to go to the field of emergency medicine, this paper came out just a few months ago, showing that it's often when the study was started in the emergency department that the problems became worse and worse. Hopefully, a few weeks ago, we have seen this study from Australia where they didn't harm the patients. There was no difference in outcome. But the chloride levels were not very high, hopefully. So, do we need a prospective randomized control trial on anything? Luciano Gattinoni would say on spaghetti versus potatoes, that no. Of course, we need prospective randomized control trials for new drugs, for some new strategies, but even for transfusions, I don't know how to do it, but I'm not sure we'll have the time to discuss it. But to compare two solutions with different content, I think it's poor understanding of the basic concepts. We just need to measure chloride levels. And before I ask our colleague what he thinks about it, I was so amazed to see this study published in the JAMA. You said you like JAMA. It's a study from Brazil. When they started the study, I said, you know, my friends, this is ridiculous. Your study does not make sense. But they completed it. And I spoke about it with the JAMA. They say, oh, it's a large patient population, so we need to publish it. But, you know, they give only 1.5 liters of one solution versus the other, and they look at mortality several weeks later. Did you really believe that mortality could be influenced by such a small thing? That doesn't make sense. And in a companion study, they gave a little bit of a little less of fluid in the first hour, and they look at mortality several weeks later. Wait a minute. That's not good. Do you agree or you don't agree?
No, I'll maybe disagree on those. So plus in Basics, Brazilian trial, plus the trial from Australia and New Zealand, Basics had 11,000 patients, plus at about 5,000 patients. both compared Plasmolite with saline. So two therapies, two interventions that are commonly used and for which there's a degree of clinical uncertainty as to whether one is superior than the other. We give them to patients every single day. There's hundreds of millions of liters of saline given yearly across the globe.
If the patient has metabolic alkalosis, which solution would you give?
Well, that depends on more than just that. I don't have Plasmolite in my hospital. We use Hartmann's. We have a different balanced solution. But one of the...
Metabolic alkalosis, you need to give chloride, my friend. That's the ABC of our discipline. So you need to give saline in these patients. If there is hyperchloremia, which solution do you give? Not saline. Don't say that we will, and these were thousands of patients, I agree, exposed to this. It could be hundreds of thousands. It could be millions of patients. The results would not be very different.
So these trials don't randomize patients to an intervention when one of those interventions is already indicated. These are for trials where there is equipoise. I am unclear as to whether to use solution A, solution B, intervention A, intervention B. So what Jean-Louis is describing is there is already a prior indication. So they're already out of these studies.
A patient is never the same as the other one.
Of course.
Do you give only one antibiotic to your patient?
So the studies that we're talking about are for situations where there is equipoise. That is what these trials look at, where there is equipoise. If you do not have equipoise, you don't randomize someone. That is just unethical. No one enters someone into a trial for which you don't think they will potentially benefit from that trial. So the studies that we've spoken about, PLUS and BASICS, they were combined in a meta-analysis which was published in NEJM Evidence at the same time. We now have very, very big numbers. I think the meta-analysis was something like 36,000 patients, of which about 16 came from these two trials. And the result of that was that there's probably a beneficial effect to using balanced solutions with the exception of traumatic brain injury. That's really useful information. That comes from randomized controlled trials, not from basing your practice on a physiological study from 40 years ago when practice was arguably quite different.
You should not give Ringer's lactate solution to patients with severe head injury because Ringer's lactate, I'm not sure, I will go back to that. Ringer's lactate solution is a little bit hypotonic. Remember, maybe you call it a Hartmann solution in Austria. In Belgium, in France, we sometimes call them Hartmann solution. Hartmann was a pediatrician. So Hartmann was treating patients with gastroenteritis, babies, young children. And so he wanted to have a hypotonic solution with only 275 millimol per liter. So, okay, that's one type of balanced fluid. But Plasmolite is as a normal osmolarity. You can give Plasmolite to patients with brain injury. But IV fluids are like drugs. Treatment should be individualized depending on what the patient needs, exactly as for any other drug in medicine. Why do you want to give only one type of IV fluid for everybody? I don't think it's valuable. I think we need to really adjust to the patient's needs. Now, maybe I can go quickly on that. When we look at mortality in our trials, we need to consider how much of this mortality can be influenced by our intervention. That's what we call the attributable mortality. And if the attributable mortality is small, you can study thousands and thousands and thousands of patients. You will never find a difference. Let's look at this trial. It's not a very recent trial. We'll go into more recent trials in a moment. But I think it's the perfect illustration of a stupid question. Pantoprazole, proton pump inhibitor, given to critically ill patients in one group or placebo in the other. New England Journal of Medicine. No difference in mortality. No difference in mortality. Okay? Let's look at the next article. Wait a minute. Wait a minute. Do you give a proton pump inhibitor to decrease mortality or to try to prevent bleeding? Wait a minute. Oh, actually, there was a significant reduction in GI bleeding, but patients usually don't die from GI bleeding. So the number of the incidence of GI bleeding went down from 4.2 to 2.5%, the difference is being highly significant. So it's a positive study, but of course it cannot change mortality. If you work in an emergency department, would you like to do a study on paracetamol for headache and look for mortality several weeks later? It doesn't make sense. But people don't think anymore. They just want to come up with large series and publications in the New England Journal of Medicine. Nutritional support, I spoke about the spaghetti versus potatoes. You give a little bit of this, a little bit of that, and you hope to see a difference in mortality. We had a roundtable conference in Brussels on this recently, and there is no evidence that any type of food in acutely ill patients will influence mortality. Look at this study. Patients with cardiac arrest without ST segment elevation, coronary angiography. Does it influence mortality? Good question. Bad question. Bad question. Why do some patients die after a cardiac arrest? They die from cerebral injury, from post-anoxic brain damage. So how do you want to influence that kind of mortality with your coronary angiogram? The problem is there. The problem is not there. Don't look at mortality. You could find some other endpoints. And finally, and I will go quickly on that, mortality is influenced by so many factors when you look at it several weeks later. Comorbidities, age, a little bit of dementia in this patient, that patient, renal dysfunction, and then personal preferences. So very often when we enter a patient in a trial, we already know whether the patient will eventually survive or die. This was my question about mortality. Do you agree with the limitations of mortality?
Mortality certainly has limitations, but it's objective, it's patient-centered, and what it also captures is unobserved mechanisms. So the trials that you've brought up, you have to remember, they've been subjected to competitive funding, they've been submitted to sponsors, they've gone through ethical approval, they've gone to the New England Journal of Medicine, very, very high standard of review. So a lot of very clever people have looked at these and with respect will disagree with Jean-Louis that maybe these are worthwhile trials and the outcomes are very, very important and they can give us the confidence to continue our practice. I imagine every intensivist here either uses or will consider using either a PPI or a proton 2 pump inhibitor for their patients who are mechanically ventilated. We do that with the confidence that these trials allow us to have, similarly with Peptic, which we had a couple of years ago. So I would respectfully disagree. Yes, mortality is an imperfect endpoint, but a bit like the comment about democracy, it's the least worst option.
Well, in a moment, I will reverse the question and we can all think about it. What are the interventions which have been shown in our field to decrease mortality? Can you think about it? And we will return to that, and I will allude to one intervention that can decrease mortality, and people have their doubts about it. Or this one. Well, whole body CT scan in polytrauma. No difference in survival. Of course, we should not do it routinely, but who will do it in any kind of trauma? But if there is a major trauma, you and I, we often ask for a total body CT scan. Do we really need a prospective randomized controlled trial on this? Once again, if you want to generalize it, then the question becomes relevant. But you know, I am president of a jury in France for all clinical research, and we received some proposals to look at echography versus no echography in the ambulance. I say, no. No, I don't want to randomize patients for echography versus no echography in the ambulance. Because if you know how to do an echography, and if you have the probe in your pocket, I will not ask you not to use it. Please do. If you think it can bring some information, please do it. You know, can we submit the chest X-ray to a prospective randomized controlled trial looking at mortality with or without it? You know. But, you know, sometimes studies on survival bring some unexpected results. This is a very recent study on etomidate versus ketamine for emergency endotracheal intubation. There is a reduction in mortality during the first period of observation, and then it's no longer significant later. Okay. What do we do with this information? Shall we really throw away etomidates? Maybe not. It's interesting. I think it's an interesting piece of information. That's the kind of study which is interesting, in my opinion. Maybe one study like this will not be sufficient to change our strategies, but it's important information. And that's what I wanted to speak about. Tranexamic acid in the polytrauma victim within 3 hours. Okay, I suppose you do it, we do it. Did you read the Lancet last week? In America, they don't use it because they say this was a huge study with the thousands of patients that my colleague loves. But it was in Pakistan, in Colombia, in Peru, etc., and the Americans didn't trust it, whereas many others do trust it because it makes sense. And so we usually give tranexamic in polytrauma. What do you think?
Yeah, absolutely. I mean, CRASH 2 came with those issues, as you alluded to, but that's an issue of interpretation, of interpreting the trial results. That's not an issue with the trial. So they're two separate things, so we can't conflate them.
Well, they bring the limitation of the trial, saying that this was performed in countries where they do not have much blood available, where the level of care is not the same as in the US, and etc. Now, I'm still worried about recombinant factor 7A from the Novo Nordisk company. As you know, the recombinant factor 7A can promote coagulation. No doubt about this. This is well shown. And there was a study performed many years ago showing that in exsanguinating victims, it can decrease the need for transfusions. It works. Now, the army, both in America, in Israel, in other countries, was keen to use it, perhaps too keen to use it. And they had some major thromboembolic complications, which sometimes need to amputate the patient, the soldier or the army person. In any case, we were asked to do a prospective randomized control trial on this substance in polytrauma to show a difference in survival. Okay. Are you sure this will influence survival in a large patient population when it may perhaps save some lives in extreme cases when we use it really rarely? And actually, we had to stop the study for futility because the mortality rate was 11%. 11% in the placebo group, 11% in the recombinant factor 7A. So there was no point. We could not show a difference in survival. So it's a very effective agent. In the second study, we also showed a reduction in the need for transfusions. So it works. We could reserve it for extreme cases, but since there was no evidence for a reduced mortality, the authorities didn't want us to have it. So we wrote this piece saying, you know, how can we make studies in polytrauma? It's very, very difficult to show a difference in mortality in polytrauma. You will have some victims who will unfortunately die early. When they arrive to the hospital, they may die from bleeding. It's not so common, but it could happen. And the others will die either from multiple organ failure or from severe head trauma. So it's very difficult. We always say, let's look at mortality, let's look at mortality. What has been shown to decrease mortality, even in trauma, you know, with, I mean, okay, we will not review all this literature, but it's very difficult to show a difference in mortality.
Yep, it certainly is. I suppose looking at that, the question I would have is, why did you choose mortality as your endpoint? It was your trial.
No, the authorities wanted this. The authorities wanted this. They said, okay, if you want this drug to be available for the severe polytrauma victim, you need to show a difference in survival. I'm sorry, I was perhaps not specific enough about it. But your question is well taken. What kind of outcome? Of course, if we intervene, hoping to reduce early survival, we need to look at early survival. I'm particularly concerned about survival after several weeks, usually 4 weeks or even longer. But this is a study on sodium nitrate in patients with cardiac arrest. Okay, didn't work. But I don't think there was another way of doing this type of study. Or here, this is, yeah, of course, if you do something that hopefully will protect the brain, you need to look at the composite outcome of mortality and brain dysfunction, the neurological outcome score, of course. But, and you will review a trial on TTM in a moment. I would like just to call your attention on TTM in general today. This is a very good overview of the issue. We don't know whether we should cool down our patients after a cardiac arrest. We still do it. We believe that there is enough evidence from preclinical studies and the very early trials suggesting it may work. So we still do it. But some people don't, and it's very difficult to really make a final decision about it. But you know, each time we do a trial, we choose one temperature for one period of time in one patient population, usually out of hospital versus in-hospital cardiac arrest. But perhaps, and we learned it from COVID, we could use platform trials so that we could have several strategies, different temperatures, different timings of interventions, and then we could stop one arm when it doesn't seem to work. We could add another arm or combine different strategies, and that could be a way to make more progress. Again, as we learned in the COVID-19 era, especially from the UK, we need to thank them for what they have done with these trials, the REMAP-CAP and the Solidarity, just to give 2 examples. Do you agree?
Yeah, absolutely. But it comes back to the point that you need randomized controlled trials. Platform trials are randomized controlled trials. Without randomization, we lose the ability to infer causality. We really need randomization. And there's been so many trials. There was a paper published just last week or the week before looking at the number of critical care trials that reported a positive effect on mortality. It was something like 300. Now they'd be small, but it was there. That knowledge was gained by running these trials. And there are criticisms, and very valid criticisms of trials, which Jean-Louis has very elegantly described already. But those criticisms lead to improvement in trial design, further sophistication of trial design, and the introduction of the likes of platform trials, basket trials, umbrella trials, all this new methodology that's used in other specialties. Oncology is always the one that's named, are increasingly coming into critical care. But the problem is not randomized control trials per se.
Of course.
This is the instrument by which we improve ourselves. If you look at the COVID pandemic, all our great progresses came from randomized controlled trials. Without recovery, the recovery platform trial using randomized controlled trials, we wouldn't have identified that dexamethasone was beneficial. remap cap wouldn't have identified that tocilizumab.
There is no discussion about this. I don't see why you come up with this. And I started the presentation by saying prospective randomized controlled trials are the best level of evidence. So we need them, no doubt about this. I wanted to call for intelligent trials versus stupid trials. And I showed you some stupid trials. But there are many intelligent ones. Well, and there are other outcomes than mortality when it's almost impossible to show a difference in mortality when you give just a little bit more of this or a little bit less of that, and you look at mortality several weeks later. But look at this. I like that kind of study where they didn't look at mortality. They said, you know, could we add some vasopressin in patients in hemorrhagic shock? And they could find that it may decrease the amount of blood products. Oh, I want to have a harder outcome. Yeah, but you know, it's already an interesting piece of information. Where do we go from there? We could discuss it further, but I think it's an interesting piece of information. Or here, is it better to intubate the trachea or to put the supraglottic airway device? It's a study from Korea, I believe, where they showed that there was no superiority of one versus the other. I think that's an interesting question. They didn't look at mortality necessarily. Or here, to facilitate endotracheal intubation, should we use a bougie or should we use a stylet? Good question. Okay. And again, there was no really difference in the facilities to intubate the trachea. It's another negative trial, but it's a prospective, randomized, controlled trial raising a question which is actually interesting. So I'm not against prospective, randomized, controlled trials, and we need them. And indeed, in COVID, it has really allowed to make better therapeutic interventions.
Yep, absolutely. We certainly need them. Observation studies are great, but they're limited by residual confounding. We need randomized controlled trials. I mean, I would disagree by calling some of the trials that Jean-Louis has highlighted there as stupid. Lots of people who've undertaken those trials would disagree with those. I'm sure the relatives and the patients who've taken part in those trials would disagree with that identification as well.
Perhaps they need to return to the basics of medicine, and I would say return to medical school for some of these trials. Now, hopefully, I have said it from the beginning for these trials. It's not when it's published that I criticize them. I said it from the beginning. It's like the studies, it's not on my slides, but the studies on septic shock with 2 blood pressure levels. Should we bring the blood pressure to 70 or to 80 millimeters of mercury or 65 versus 75? Of course there is no difference in mortality. I told them from the beginning. Because some patients are very happy with a mean arterial pressure of 65, and some patients need a mean arterial pressure of 75 during septic shock, and the other way around. There are some patients who need 75, but they would be less well with 65. They would not be happy with a mean arterial pressure of 65. We all say that we need to personalize medicine, and then there are some people who say, oh, no, let's look at all the patients and treat them exactly the same. Same IV fluid, the same blood pressure level. You know, I reviewed for the JAMA the Canadian study on so-called elderly patients with 65 years of age or older. Again, 2 blood pressure level in septic shock, no difference in outcome. And I told the editors, I said, you know, and that's exactly as Rob said, you know, the trial was well conducted. The idea was stupid. But the trial was well conducted, so I know you will take it. I know you will publish it, because the JAMA loves to publish randomized controlled trials, even when the message is not very important. And indeed, they published it. So, okay, so we can discuss it. But hopefully, we can personalize our therapies.
And we might discuss that in a little bit when I get onto my slides later.
Okay, well, I may keep it short. I had some further thoughts about what kind of other studies we need and where do we go from there, in addition to prospective randomized controlled trials or as part of prospective randomized controlled trials. I think in the emergency room today, there is a lot of interest for biomarkers, not only to identify the patients who will need antibiotics, source control, or if the biomarker levels are low, if we can do without it. Remember, that's how procalcitonin was developed. Very nice study published in the Lancet where they showed that procalcitonin measurements could decrease the administration of antibiotics, not promote it. And so, okay, these are the studies which are very, very interesting. And also, this could help in triage, as they say in English. It is that some patients may go home, some patients may go to the regular floor, and some patients may go to the intensive care unit. Have you seen this very recent paper? It's very relevant to emergency medicine. It's not a prospective randomized controlled trial, but okay, it's just an inquiry about the discharge of outpatients home with a diagnosis of possible sepsis. And the conclusion of this inquiry was that it depended very much on the doctor. For similar cases, some doctors would hospitalize, some patients would send them home. So that outlines the need to do some work in this field and to help to better identify the patients who should stay in the hospital and perhaps should go to the ICU right away from the others. And this could be based on biomarkers, it could be based on some clinical criteria. You could use a scoring system, maybe, because sometimes at 3 o'clock in the morning we are very tired and we can make errors. We are humans. So scores may perhaps help us to take the right decision. So that's what I mean with this slide. Should I send the patient home or to the regular floor or maybe to the ICU? And I think there is a lot to say about the organization of emergency rooms, especially in the future. I like to speak about the future of medicine and the future of emergency medicine and intensive care medicine, how we will work at the level of the triage nurse with emergency doctors and other specialists in the hospital. I think I took out the slide, but I was reading just a few days ago a paper in an American scientific publication saying that now in the US they have too many emergency doctors. Too many. They don't know what to do with all them. In Belgium, we don't have enough. There is a tremendous lack of emergency doctors. And we can also discuss it. It's not really a prospective randomized controlled trial, but there is stuff to be discussed and ameliorated. And that's indeed part of organization. Very quickly, I don't know. Right now, more and more people go to the emergency room with minor things because we know we will have the specialist opinion, the blood tests, the x-rays, all together instead of going to the general practitioner, and it will take 3 days to have all this data collected. But how will it be in the future? Do we need to construct very big emergency departments? There will be artificial intelligence, of course, with facial recognition. The mothers will not necessarily rush to the hospital for a baby who doesn't look too well. Maybe she could be reassured by the artificial intelligence program that could, perhaps looking at the baby, could help to to have a strategy. So perhaps the baby should not be brought to the hospital right away. So that could make less people going to the hospital. Telemedicine will change our world, and also in the emergency department, when we arrive, a number of tests will be done automatically. Our urine will be analyzed immediately, and this will bring some important information, etc. So these are elements that could improve our organization. I went not so long ago to visit the Samsung Hospital in Seoul. That's really a fantastic experience where you can follow on the screen the patients in the emergency room, and at the other side the time they spend there. And these are also some very interesting reports to make. These are not really prospective randomized control trials, but these are, I think, interesting type of studies.
Yeah, absolutely. I think biomarker-guided trials will be the next tranche of trials that we see coming through. Personalized medicine, precision medicine, this is going to be very exciting. There'll be a lot of trials coming through on that. So, yeah, will I maybe bring up some of my slides? Would that be okay?
Maybe the last minutes.
Last minute, okay.
Well, we started at 2:30. It's until 4, huh? Yeah. So very quickly, I think that the future will also be pre-hospital medicine. We have not done enough there. Lots of things can happen in.
Anything else?
No, thank you. Fine, thank
Nope,
you.
nothing, thank you.
Of course, a lot of things can happen before the patient reaches the hospital, and we need to work on that. These are the old stuff we know, scoop and run versus stay and play. In Europe, we like these medicalized ambulances. In French-speaking countries, we would speak about the SAMU system because we learned it from France. And I believe personally that these can have some advantages, but we don't need doctors in an ambulance. I think so. I think in the future we'll have good paramedics. But there is much to be done. And with telemedicine, we will, of course, control better what's going on outside the hospital. But have you seen this paper already a while ago saying that pre-hospital intubation is associated with increased mortality after a traumatic brain injury? Interesting information. What do we do with that? Oh, okay, that's about the physicians, but I can skip it. The point I would like to make is that we need more interaction between what's going on before the hospital, what's going on in the emergency room, what's going on in the intensive care unit and elsewhere in the hospital. So instead of just rectangles, put one after the other, it should be a number of cycles as the transition could be actually improved, as we learned in the field of trauma, the chain of interventions. So I think we don't need a doctor in the ambulance, but we need telemedicine system. And we can, of course, send already some information. EKG, echography can be sent on the smartphone of our doctors in the ICU. We'll have mobile CTs. We could have CT scans already in the ambulance before the patient arrives to the hospital. And we could do a number of things in these ambulances. Of course, there is a big issue there. It's the time to the hospital. Because in the Graz region, we may be quickly in Graz if it's really in the surroundings. In Belgium, there are hospitals everywhere. We're always close to a hospital. We may not need to do too much in the ambulance. But when we are in Scandinavia or even in a remote region of France or in the mountains in Austria, perhaps it may take a bit more time. And having the emergency room to be prepared for the next admission is really very important. Do we need a neurologist for a possible stroke? Do we need a cardiologist for a possible myocardial infarction? Do we need a surgeon for possible trauma, etc.? And this information could be brought earlier And really, there is a lot to be done there and a lot to be studied in this context. This is an interesting study. I'm sure Rob will disagree with me, but it's a paper I reviewed for the Lancet. They wanted to give antibiotics to patients with sepsis in the ambulance. Huh. I was very keen to review it. I thought, that's interesting. Yeah, we could give the antibiotics before the patient arrives in the hospital. But then, the data showed, I'm sorry the slides are a little bit altered, but these patients had infection. That's sepsis. They had fever, that's all. And associated tachycardia, or associated hyperventilation. In the ambulance, we all hyperventilate when we are in the ambulance. So, just fever. And they gave some ceftriaxone. What was the mortality rate? 8%. What was the number of patients admitted to the ICU? Less than 10%. That's not what we want to see. It's a negative study, but of course it's a negative study. It could be harmful to give antibiotics already in the ambulance if it's ceftriaxone for any patient with fever. We have other antibiotics, and as I said, we could use cheaper and more widely available antibiotics like amoxicillin to these patients. Why do you need a cephalosporin for all patients having fever in the ambulance? Do you agree or not? You may disagree with me.
No, you're right. I mean, by no means is every trial perfect. Clearly, there are some issues with this trial that the next trial will improve upon. We learn. So
I invited the authors to remove the word sepsis and say they were infected, but they didn't want it. And the editor of the Lancet just wanted to have it published because he knew that this would be cited. It's a prospective randomized controlled trial in the ambulance. And of course, that's interesting. This is not a prospective randomized controlled trial. It's more a retrospective study of less than 500 patients. It's not a very high level of evidence. But I like the message, which is that perhaps the pre-hospital administration of noradrenaline in septic shock may decrease mortality. Decrease mortality, perhaps. So that could be also a trial to be done in patients with septic shock. I didn't mention it. There was a study from Canada in the JAMA some time ago showing that giving more fluids in the ambulance may result in less organ dysfunction. That was also interesting. I didn't put it there because it's not very recent. This is very recent. And I think you will, that's about pre-hospital plasma transfusion. That could decrease mortality in the bleeding patient when transport times are longer than 20 minutes. That's interesting. We could already give blood products to the patient before he or she arrives in the hospital. And I think you will discuss the refill study, so I have difficulties with this trial. I find the idea interesting, but I'm not sure that the patients in the experimental group received much blood before they arrived to the hospital. But actually, this was another trial, small trial, where pre-hospital, will you speak about it too? No? That's a small trial, but pre-hospital mortality could be reduced by the administration of transfusions before the patient arrives in the hospital. That's what Army medicine would tell you as well. Start the transfusion as early as possible. So I will stop here with my messages. Randomized controlled trials are always preferable for many questions, but they are usually negative, and mortality is a very difficult endpoint. There are other types of studies, especially about technological developments, organizational issues. We cannot always randomize patients for one organizational scheme versus another one. Optimal process of care requests a better collaboration between the emergency department and other departments. and pre-hospital medicine will improve. There are a lot of things to be studied and a lot of trials to be performed. We still have many, many questions, and I'm sure we will agree on that. But we need to do intelligent trials.
Negative, as such, trials still generate very important information. If the two interventions being compared are more, if one is more resource-consuming than the other, those trials give us the confidence to use the less expensive or less resource-intensive intervention. Very, very important information. Even though the trial is negative or inconclusive, doesn't show one is superior to the other, it's still hugely important information.
Why would you say it's from the Brazilian trial on 2 types of fluid? There is no difference in mortality, but there is no difference or hardly any difference in interventions. So how is it helpful?
Depending on where you work, plasma light is multiple times more expensive than saline. And as I mentioned earlier, vast quantities of these agents are used across the world. That's a huge economic saving depending on where you work in the world. So
that would be a wrong message to say, give saline, give saline, give saline. It's cheaper than other solutions. No. If there is hyperchloremia, you need to stop giving saline. You don't want to induce renal dysfunction.
That's back to our initial point that where you already have an indication for an intervention, you don't have equipoise for that intervention.
No. For any patient, if you see the chloride levels going up, you need to stop. Stop giving potassium when the potassium starts to be above the normal value. You know, it's the same thing again and again. Now, I don't think that a negative trial always brings you something. You know, again, in septic shock, knowing that blood pressure at 65 or 75, same outcome. So don't look at blood pressure. Blood pressure doesn't matter. Wait a minute, it does matter. That's how with the Surviving Sepsis campaign, we recommend to individualize our levels of vasopressor support. That's why at these meetings, we show how to optimize vasopressor support. But one patient is not the other. It's not the same for everybody.
So what I'm going to do is look at just five big papers from the last, the remit we were given was the last 10 years. I've gone for 4 very recent trials and one a little bit older. The trials that I've chosen are intensive care trials predominantly, but there's a couple of pre-hospital trials in there as well because this is an emergency medicine conference. But I hope the trials that I've chosen that are ICU-based are extrapolatable to a degree to managing critically ill patients outside the intensive care unit. So the first paper, TTM2, you probably all have seen it. It was published last June. We hosted the trial results presentation online at Critical Care Reviews. So it was a multi-center open-label randomized control trial. Everybody, I'm sure, is familiar with it. 1,900 patients out of hospital cardiac arrest. Patients were comatose when they reached the emergency department. The comparison, normothermia versus hypothermia. And there were 3 time periods. The intervention period lasted 40 hours. So 28 hours at target temperature. So for those who were cool to hypothermia, 33 for 28 hours. They were allowed then to warm up to normothermia over 12 hours. And for those patients that remained comatose, their temperature was managed up to a further 72 hours. And the groups split beautifully in terms of their temperature obtainment. The primary outcome was 6-month mortality and no significant difference. So a negative trial as such, a neutral trial, others would call it, or a null result. Is this useful information? Absolutely. This is a landmark trial. This is hugely important information. There's the relative risk reduction and the Kaplan-Meier curve. The secondary outcomes were similar between the 2 groups. This is practice changing. We no longer need to cool our patients. We still manage temperature, but we no longer need to cool. We don't need to induce hypothermia anymore. Half the patients who were randomized to the normothermia arm didn't need to be cooled. They will sit with a temperature less than 37.5 or certainly less than 37.8, which was the threshold to induce cooling. So a negative trial yet is hugely important for everybody. And the point I wanted to bring up, looking at this trial, and we'll hear what Jean-Louis has to say, is that science is an iterative process. The contemporary investigation of targeted temperature management began here in Austria 20 years ago. Austria, I think it was Vienna and Melbourne with Stephen Bernard. Those two trials were both small, both published in the same issue of the New England Journal of Medicine, but both quite small. They changed practice 20 years ago, and everybody started cooling down to 32 to 34 degrees Celsius. If those two trials were published today, I don't think the whole world would move. And that, again, is a reflection on our increasing maturity in interpreting trials. But if the trials aren't done in the first place, then we can't progress. So we need the trials. Science is iterative. Those two trials happened. We've had numerous other trials, including TTM, which was published in 2011 or 12, 33 versus 36. Again, no difference. Important information. We then were able to manage patients at 36 degrees Celsius with the confidence that we would probably get equivalent outcomes to 33 degrees Celsius. Is it the avoidance of fever that is the issue? Well, TTM2 has brought us up to 37.5, and TTM3 will evaluate whether it is indeed the avoidance of fever that is the issue that we need to address in post-cardiac arrest management. So, Jean-Louis, this is a journey from 20 years ago to now, from cooling to maybe we don't actually need to cool.
Yeah, I agree. And I have a philosophical concern. It is that, again, it's a trial showing that something doesn't work. But I agree with you. I have nothing against that study, which was discussed again at our meeting 3 weeks ago. I just referred to the consensus of experts saying that we don't know what to do today. We don't know whether we should still cool the patients or not. But I agree with you that this large trial indicates that the benefit is probably very small to cool down the patient. And I fully agree with you that, of course, prevention of fever is the most important thing. But I would like to see more trials showing that there is something new. Exactly as I was very excited, and I lived it very actively, when the study from Austria and from Australia came together in the New England Journal of Medicine, as Rob said. I was very excited because we had something for cardiac arrest. What do we have today? We even doubt about the medications we could give. Adrenaline, yeah, maybe yes, maybe no. Bicarbonate, no. Calcium, no. What do you give? Cardiac massage? Yeah, I know, but you know, one day we'll discover that cardiac massage doesn't work. No, I'm kidding.
So, brings us very nicely onto the second trial, which I've chosen. And again, we hosted the results of this. Lars Andersen from Aarhus in Denmark was the chief investigator for the COCA trial, calcium in out-of-hospital cardiac arrest. So I think this is very relevant to this audience. So published in JAMA last August, I think it was. Yeah. So multi-center, blinded, randomized, very, very good trial, very robust. 397 patients, didn't quite achieve their sample size, and we'll see why. Patients who were in out-of-hospital cardiac arrest, so they were still in cardiac arrest. And they were randomized to either 5 millimoles of calcium delivered either intravenously or intraosseously, and that could be repeated a second time, or placebo. The primary outcome, return of spontaneous circulation. And there's the figures. 19% for those who received calcium, 27% for those who received placebo. And the relative risk, so much less likely to achieve return of spontaneous circulation if you were administered calcium. 30-day survival, again, almost half in the calcium group, and those who survived with good neurological outcome, again, almost half in those who received calcium. So it raises a couple of very interesting points, and one of which was probably my main take-home from the COCA trial, was this concept of you can't do harm. what harm can it do? Someone is already in cardiac arrest. You've nothing to lose. You certainly do have something to lose, because some of those people will regain return spontaneous circulation from your resuscitative efforts. Well, I won't make the other points because I might bring those up later on. COCA, fascinating trial. Would we have learned that without doing the trial? It's estimated 90,000 patients a year in America are treated with calcium for in-hospital, for cardiac arrest, I think mostly in hospital. 90,000 patients. That's a lot of people. Jean-Louis?
Actually, calcium administration in cardiac arrest was abundant in the late 70s when I was in training, because and actually it's part of my PhD thesis to show that calcium antagonists may protect the heart during cardiac arrest. Calcium antagonists, because we were already thinking that calcium would not help. Because when you look at arrested hearts or profoundly ischemic hearts, the cells are full of calcium. They are full of calcium. Why would you add it? Exactly why would you add chloride to patients who have hyperchloremia? But here, why would you like calcium if the cells are already full of calcium? And I'm sure our friend knows very well about it too. We were trained by the same Dr. Weil in Los Angeles, and at that time we abandoned calcium in cardiac arrest. So I found it bizarre that the story was again looked at, because clearly calcium has not been used for many, many years. Do you agree? 100%. So who does give calcium in cardiac arrest? Except if the patient is known to have hypocalcemia, maybe, or is known to be on calcium antagonists, maybe, or is with hyperkalemia. These are the three potential indications. Does anyone give calcium or want to defend the administration of calcium during cardiac arrest? So I'm not convinced that that trial had to be done. I agree with you that once they decided to do it, they did it well. Okay, but the rationale to me is relatively weak.
Yeah, except it's common practice in North America. So there's a large group of patients are going to benefit from this trial having been done. Number 3, refill. So we've already discussed it this morning. Jean-Louis has alluded to it again. We were lucky enough to host the results March 7th. Fascinating trial. So Nick Crombie was the chief investigator, published in Lancet Hematology. So multi-center, 4 trauma services in the UK, open label, randomized. 432 patients. I think the power calculation was for, I think it got elevated to something like 637. Trauma-related hemorrhagic shock and hypotension was the entry criteria into the trial, the inclusion criteria. Patients were randomized to either receive 2 units of red cells and lyophilized plasma, or else to up to 1 liter of saline. So not big volumes, which has been one of the criticisms of this. The primary outcome was a composite of episode mortality or impaired lactate clearance. And that's the primary outcome. See, the intervention group, the primary outcome occurred in 64%, the control group 65%, so no big difference there. Episode mortality 43% versus 45%, so again, very, very similar. And the reason I chose this was that in medicine, there's often momentum in a certain direction. In trauma, the momentum is towards more blood products in pre-hospital use. Pamper certainly reported a beneficial effect. Combat didn't, but there is so much momentum in this direction following the conversation online and social media during refill. So many people commented that they didn't have equipoise for this trial, which I found fascinating. Didn't have equipoise for a trial which ultimately demonstrated an inconclusive result. The boundaries of benefit and harm in the 95% confidence interval include both. So absolutely fascinating that people are so confident in what works and what doesn't work that they wouldn't take part in a trial which is ultimately shown to be inconclusive. It's a bit similar to where we were a long time ago with transfusion thresholds. Patient has acute coronary syndrome, they must have a transfusion threshold of 10, and we've chipped away and chipped away and chipped away and chipped away. And last year we had the reality trial in JAMA, which compared a more restrictive transfusion threshold, I think it was less than 8, with 10 in patients with acute coronary syndromes. And although it didn't show a significant difference, the point estimates were all in favor of a restrictive transfusion threshold. So it's interesting. So we need to look for the signal. We need to have the evidence before we move, or at least as we move, and not get caught up in the momentum of everyone thinks this must be effective. All our interventions come with harm, including blood. If you ever look at the metabolic profile of a unit of blood, it's remarkable. A unit of blood that's about 30 days old, its pH is less than 7. Its potassium level is something like 12 or 14 millimoles. It's grossly anaerobic. The lactate is very, very high. Depending on whether you warm it up or not, it's cold, it's hypocalcemic. It's obviously anticoagulated. So in terms of giving someone a fluid, blood's about the last thing you want to give. If chloride is bad, blood's an awful lot worse. The red cells don't actually transport much oxygen. So it's a fascinating trial. So the momentum is all blood must be good. Hang on, let's have a balanced overview of this, and maybe let's do a trial and see where we end up.
It sounds like a dogma. It's not one trial that will make the whole story. The questions I have about the refill trial, and we discussed it in Brussels 3 weeks ago, and the investigators were there. It is first that we don't know exactly. It's very difficult to find how much blood they gave in the ambulance before arriving to the hospital, because the time to the hospital was rather short. And you know, the whole paper, read that paper, it's open access. The whole paper is about safety, about secondary analysis, but you cannot really easily find the amount of red blood cells that were given in the two groups. And by the way, they speak about lactate clearance, but they didn't study lactate clearance. They looked at the time course of lactate levels. Lactate clearance is primarily from the liver. You need to give hypertonic lactate to study it, or radio-labeled lactate to study it clearance. Lactate levels do not reflect only clearance, and in these cases, they reflect production more than clearance. So, but that's a minor thing. It's not one trial like this, without differences in outcome, that will tell us that we should stop having blood in the ambulance or in the helicopter for people who are in massive hemorrhage and have to be transported for long distances. That would be, if you have blood there, if you have an exsanguinating victim in your ambulance and you have 20 minutes to go to the hospital, would you say, no, I will not give the blood? No, there are a number of logistic issues. It's not so easy to say, put some blood in the ambulance and that's it. I agree. And you need to be in a region where there are many major trauma cases to make sure that indeed the blood will be available at all times and for these victims. But it's not one single trial in a given environment that will stop that research. Look at the study that I presented very briefly on plasma administration in the ambulance, resulting in better outcomes. Look at the study in shock that I briefly presented, with less pre-hospital mortality with blood. So it's not because there was a recent trial showing no difference that the entire story is over, I'm afraid. You know, we need more studies.
Absolutely, definitely need more studies, and the concept that a treatment that's given in the emergency department shouldn't work pre-hospital, obviously, is false logic, but the question is whether it needs to be delivered that early or not to make a difference, and the logistical issues that arise in having to carry blood. But it's a fascinating trial, and it will be built upon science as iterative. So, number 4. Again, Jean-Louis has already alluded to this. This is the 65 trial. So, Francois Lamontagne, who was one of the co-chief investigators of that, presented the results in Belfast a couple of years ago. You might maybe recognize the staircase. It's the famous staircase from Titanic. Little aside, they don't actually know if that is the staircase from Titanic. They don't have the drawings. That's the staircase from Olympic, which they've assumed. Olympic was one of the sister ships that was built with Titanic, which they assume is the same as Titanic. So you see it in the movie, it's actually the staircase from Olympic. There you go, small piece of trivia. The reason I know that is Nicholas Nielsen, who was the chief investigator for TTM2, his best friend is someone with a historical interest in ship's architecture. So there we go. Via Sweden back to Belfast, we get that information. Moving along. 65. Okay. Published in JAM a couple of years ago, multi-center, open-label, randomized controlled trial. 2,500 patients in the ICU with vasodilatory hypotension. And they were randomized to a map of 60 to 65 or usual care. Primary outcome was 90-day mortality. And the 90-day mortality was 41% in those who were randomized to permissive hypotension, as the investigators called it, or 43.8% in those who received usual care. And there's the Kaplan-Meier curve. And in those with chronic hypertension, of course, everyone says, oh, it's the higher blood pressure. They need a higher blood pressure. Maybe not. There's the mortality, 38 versus 44, 38 in those receiving permissive hypotension. So the point from this is that we think we understand physiology. We think we know what is best for the patient. Until we do the trials, we quite often don't, and our understanding of physiology is quite often incomplete, and it is augmented by doing these trials. Now, there have been a couple of other trials looking at this. Ovation, it was a small pilot. Sepsis PAM, the results were the opposite of this, but this is a very big, robust trial. So, for you managing a patient, maybe in the emergency department or in the intensive care unit, do you need to target a higher blood pressure? 2,500 patient trial, robust 2,500 patient trial would suggest, no, maybe you don't. And of course, the question would be asked is, why? Well, the patients who were managed with the hypotensive approach, they had less noradrenaline. They got less noradrenaline and they got it for a shorter period of time. Catecholamines come with harms. Everything comes with harm. And one of the great benefits of doing trials, even the neutral trials and the negative trials, is that it allows us to identify interventions that maybe are not beneficial. So 65, fascinating trial. Maybe our understanding of physiology isn't always what we think it is, and maybe targeting our treatments based on our understanding of physiology sometimes isn't the way to go.
Again, negative trial from the very beginning. We knew it would be negative because blood pressure level must be individualized. So what do you tell your medical students when we are at the bedside and when the patient with septic shock has a mean arterial pressure of 65 or 70, whatever, and is not making urine? What do you do? I ask the nurse to raise the norepinephrine levels and see if urine output comes back. And I look, now that we no longer sedate our patients, I try to see how the brain works. That's basic physiology. Basic physiology. Is the brain well perfused? Examine your patient. Don't put in the computer, bring the blood pressure to 65 and I'll go and have a beer. No. Examine the patient and individualize your therapies. That was the message before these trials, the French trial like this one, and it remains the same message after the trial was conducted. Again, no difference, no difference, no difference. But you mix so many different patients that at the end, you no longer get the very important information. And as you say, very often patients with a history of hypertension need a higher blood pressure than the others. Elderly patients with some degree of atherosclerosis may need a higher blood pressure than younger individuals without arteriosclerosis. And, but instead of guessing, and very often we don't have this information available, it's better to test the system. That's why I love emergency medicine and intensive care medicine. You can test the system. You give some fluids, you see how the patient responds. You raise the blood pressure, you see how the body responds. So that's great in medicine. So we don't allow the computer to drive the treatment.
So I have a question, Jean-Louis. What do you base your approach on? You say personalize it, look at the patient, but what do you base that on? I mean, I can turn to 65 and say, here is the outcome. Our understanding of physiology is that we think patients who are chronically hypertensive need a higher blood pressure, yet the result is the opposite. So what do you base that on?
Yeah, I'm not sure we have the time, but because it's a lecture per se, but we look at signs of tissue perfusion. And there are 3 windows for acute circulatory failure. The skin, that's how we look at the skin, the capillary refill time, if you like to measure something. But if you just feel the skin and look at the degree of reperfusion, it's already a good thing. Urine output and mental status. If you feel that the patient may be with a somewhat low cardiac output, inadequate cardiac output, with excessive vasoconstriction, then you could consider giving more fluids. Or if you have already done a fluid challenge, and if you see that the patient does not respond to more fluids, you could perhaps add a little bit of dobutamine as an inotropic agent. Just do it, try, and see in the next minutes if tissue perfusion improves or not. What you could do before that is an echocardiography to see how the heart pumps. And indeed, you can evaluate the cardiac function. And if it's altered, it's an argument to give dobutamine. Or if you have a central venous catheter in place, you can take a sample and measure the central venous oxygen saturation, which is a surrogate for the mixed venous oxygen saturation that requires a Swan-Ganz catheter to measure it in the pulmonary artery. But if the SCVO2 is low, significantly below 70%, if it's 60% and in this area, then you may have to consider more, giving more fluids and giving an inotropic agent. So there are a number of things to be done. Some people want to simplify the management of critical ill patients, but it continues to be a challenge, you know. There are a number of things to look at. And I didn't mention the lactate. You know, repeat lactate levels every hour or so. It's not necessary to measure it every 10 minutes. But if you repeat, because the blood levels do not change so quickly. But if you measure it every hour, they should go down as the production of lactate should go down. It's not clearance, it's production that could go down. And so measure it repeatedly. And that can show you if you are on the right track or not. If you see the lactate levels do not go down or even increase, you may need to re-examine your strategy. Perhaps we need to go back to the CT scanner to try to find out if you are not missing a source. If the patient was operated, maybe we need to talk to the surgeon and see what's going on there. So we need to reassess our strategy based on these lactate levels.
I'm always fascinated by the promotion of a physiology or personalized guided approach. The FEAST trial, so African children with febrile-related hypotension, randomized to 3 groups, saline bolus, albumin bolus, no bolus. The groups that got saline and albumin looked better initially, the personalized medicine, physiological response, and then they died. The ARMA trial, 12 mils per kilogram versus 6 mils per kilogram tidal volume ventilation, those that got 12 mils per kilogram oxygenated better, looked better on the ventilator, and then they died. So it's fascinating. I always find it amazing to look at the physiology, but it's harder endpoints down the line which are arguably more important.
Well, the last tidal volume story, is not a good example because indeed it's harmful. And we had already a very good evidence from preclinical studies showing that using large tidal volumes can alter the lungs. That's what we have done with our respirators. It was really iatrogenicity. And that study is one of the only studies in critical care medicine showing that we can have a difference in mortality when we do one thing versus another. The other studies are from Laurent Brochard trying to avoid endotracheal intubation by CPAP or non-invasive ventilation, which can improve survival. So these are exceptions to the negativity of many of our trials in our field. And so indeed, we still have difficulties with this African trial without much monitoring. They did not monitor anything, and clearly giving too much fluid was harmful in these particular conditions. But there are plenty of studies showing that in sepsis, you need to give fluids. Our North American colleagues sometimes give too much fluids because they go by formula and they give 30 cc's per kilogram in 3 hours in every single patient with septic shock, which is not a good idea. We need to individualize fluid administration as well.
So we have about a minute. Do we have time for the next one? 90 seconds. Okay, let's run through this really quickly. So number 5, BICAR ICU. Multi-center open label, randomized trial, just under 400 patients. The inclusion criteria, there were a number of them. These are the main two: pH less than 7.20 and a sodium bicarbonate of less than 20 millimoles per liter. So severe metabolic acidemia. The intervention group got 4.2% sodium bicarbonate up to 1,000 mils. The other group got nothing. Usual care. Primary outcome, composite 28-day mortality and at least one organ failure. So the primary outcome occurred in 66% of those who received sodium bicarbonate, 71% of those who didn't. 28-day mortality, 45%, 54%. So there's the Kaplan-Meier. And renal replacement therapy, 35% versus 52%. And again, that's the cumulative graph of the requirement for renal replacement therapy. So the reason I've included this one is this challenged my dogma. My dogma, my belief, my prior before this trial was that bicarbonate was probably harmful, worsened intracellular acidosis. I never used it. But the data came along. A trial that I wouldn't say I didn't have equipoise for, but certainly have equipoise for it because I didn't have good data to base my strong conviction on beforehand. But this was a very, very nice trial, very, very useful, and yeah, like I say, it challenged my prior belief.
Absolutely. It's not a definitive trial, and the French authorities have subsidized another larger trial because the differences are not entirely convincing, not enough to give bicarbonate quite routinely in patients with metabolic acidosis, but certainly enough to continue and do further trials on this, definitely.
So I'll finish with a little comment about being confident. Science changes. Trials change our understanding of physiology, of biology, of diagnostics, of therapeutics. And that's wonderful. We work in fantastic specialties, and we're very, very grateful to those who do generate this information, and of course the relatives and patients who contribute to our understanding of medicine. And if you are interested in trials, come to Belfast in June. We've got a lot of great trial results and the best trials of last year to review with their chief investigators.
We agree on these conclusions, yeah. We are making great progress, and we need to go further and faster with intelligent trials. Yeah, absolutely. Thank you, Shane.
Thank you, Shane.
Thank you. It was a pleasure.
I think we will walk out, so have a meeting at the Genius Bar of the AGN. together with both gentlemen. Thank you very much.